Okay, so I think we will begin then, unless others join. A few others I can see still joining us, but good morning everybody, and a very warm welcome to you. I'm Elizabeth Bradbury. I'm a director at the Advancing Quality Alliance, and it's my great pleasure to be chairing this masterclass. We've got participants, nearly 200 people have registered for today's session. You come from many different areas of work and bring really rich experience. So we hope we'll have lots of conversation with you in the chat box and in the Q&A session. So thanks very much for putting your expectations of the session, what you'd like to achieve, into the chat box, and your questions as we go along. I'm going to do a few intros now, and firstly I'm going to hand to Alana, our colleague Alana, and ask her just to run through a bit of Zoom etiquette and introduce the support team. Thanks, Alana.
Thanks, Elizabeth. Hi, everyone. My name's Alana. I'm the membership lead at Northwest Employers. So I can see quite a number of our members in here, which is great. So I'm just going to very quickly go through the Zoom support with you. Everyone's probably quite familiar with it, but I'll just kind of remind everyone. So as Elizabeth said, we do have over 120 people on the session today. So if you could keep yourselves muted for the time being, and then when it comes down to questions, we can ask you to unmute your microphone and invite you in to speak. So the button is just on the bottom left when you wave your mouse in the middle of your screen. We are recording the session today, so by all means keep your camera on. We'd love to see who's in the room, but equally if you don't want to kind of your face to be recorded, or you don't want to be seen, there's a button next to the mute microphone button that you can stop and start your video. If you click on participants, if you want to see who's in the room, you can click that and it'll pop out a box for you. There's also an option to raise your hand in there as well, just along the bottom. If you want to get any of our attention, if you need tech support or you've got a question, pop your hand up, and there's a couple of us that'll keep our eye out for it. And then finally, the chat box. So again, if you click on the chat, which I can see everyone's using at the moment, if you have any burning questions, pop them in there. We do have a team, some of the team checking on that. So we will kind of be bringing in questions throughout the morning. So don't wait until we ask for them. I guess if there's something that you want to ask in the moment, just pop it in there. Equally, if you need any tech support, pop your question in there as well. And there should be an option to select who you want to send a message to. So if it is tech support, it'd be myself or my colleague Effie. So if you just search for us in that little box there, you can send us a direct message if you've got any questions. I've also popped my number in there as well. So if you need to give me a call, you've got anything tech wise that you need help with, you can always ring me. I would suggest closing everything else down in the background, your emails, any other apps you've got open, and if you're having issues, try and leave the session and we'll be able to bring you back in, and hopefully that'll fix things. So yeah, looking forward to it. I hope you have a great session, everyone.
Thank you, Alana. And thanks very much to you and colleagues for organising today and providing support throughout. Before we start, I'd like to just explain a little bit about the partners who organise these masterclasses. We have a whole series of them and have done now for several years. And I work for one of them, the Advancing Quality Alliance. The 5 others are the Innovation Agency Northwest Coast, the NHS Northwest Leadership Academy, the Northwest Association of Directors of Adult Social Care, ADAS, Mersey Internal Audit Agency, and Northwest Employers. And we have collaborated together on designing and delivering these masterclasses, as I say, for several years, trying to draw in topical national and international speakers. There's been a real richness in us providing a forum, either in person or virtually, for our different audiences to come together and to work on areas of mutual interest. And of course, integrated systems of care are something that we're all really fascinated by and all committed to improving. So what we're going to do is have 3 different speakers today, offering a different perspective, a different lens on system integration. We're going to start with Edward Jones, who comes from a perspective of policy, and we'll be talking about the thinking from NHS clinical commissioners. We will have Sakthi Karunanithi Director of Population Health will be thinking very much about that population health and well-being agenda from a system angle. And we will have Mike Roscoe thinking about the provider angle and talking about his experience as Director of Ops at St Helens and Knowsley NHS Trust. We will have plenty of time for the speakers to present, and we can have Q&A to the speakers. So what I'm going to ask them to do is to speak uninterrupted, unless they want to come to you and start a bit of dialogue with you as the audience. And then we'll look at the questions that you might have put into the chat box. And Pam and Kath from our team today will facilitate that Q&A with the panel, with the individual speakers. And then we've also got a panel session at the end of the day where we'll draw it all together and pose questions to the panel. Please do feel free to step away and have a quick cup of tea if you need to, or stretch your legs. We haven't built in an actual coffee break. And as we said earlier, the session will be recorded, so don't worry that you might miss something if you need to step away for a quick comfort break. I think that's all about the logistics. I just wanted to set the scene for a moment. As we say, the title of this session seems so topical at the moment. So Leading for Change, the future of integrated care systems. We know the future is integration and collaboration. And as it says in the NHS white paper, collaboration should be the guiding principle of the NHS and its partners. And it's something that we've all been working towards for many, many years. It was outlined in the NHS plan. And now, of course, we're at the point of edging towards legislation on the topic, and had a huge lived example of mobilising together to collaborate and integrate our systems during the pandemic. So we want to explore that angle with you a bit, but particularly focus on how we lead together and how we work with different partner agencies, statutory, voluntary, and with local citizens in place. I'm going to say little more other than I hope that this will be a really rich and interactive discussion. And I'm going to hand over now to Edward and introduce Edward Jones as our first speaker. Edward joined the NHS Clinical Commissioners Network in February this year with a long background in policy. He had 5 years working for a public affairs agency where he specialised in health policy. And he's previously worked on policy and communications for lots of different organisations, including the Shelford Group, Unison and Royal Colleges. Prior to that, he was a parliamentary assistant to an MP in the House of Commons and has an academic background, having studied history and politics at Exeter University and public policy and administration at the LSE. So he has a real rich experience. And Edward, we're going to really look forward now to hearing from you as you start as our first speaker. Thank you.
Thank you very much, Elizabeth, and it's a pleasure to be here. I hope you can all see and hear me properly. If you can't, please do shout. I'm Edward Jones. I'm NHS Clinical Commissioners Policy Manager, and I'm our policy lead on legislative reforms. And I also sit across the NHS Confederation ICS network. I've been asked to step in today by Lou Patton, our Chief Executive, who doesn't mind me letting you know that she had to pull out late this week due to a family bereavement. But I do hope that I'll be able to provide an overview of the legislative reforms and our viewpoints on them today. It's probably worth me clarifying as well that NHS Clinical Commissioners, we represent CCGs, but we are a network within the wider NHS Confederation, and we also have launched our NHS Confederation Integrated Care Systems Network, and my role sits across the two. So hopefully I can provide a bit of perspective from both angles for you today. I'm going to look at some of the substance of the government's legislative proposals today and the Confed view on them to provide a bit of context for the following speakers. I'm sure much of this will be familiar to many of you, so apologies if I'm telling you things you may already heard, but I'll try and be brief on some of the substance and focus on pulling out some of the key areas that we see in the bill and provide the Confed's viewpoint on them. what we think our members agree with and where our concerns are, before looking at some of the next steps and timelines for implementation. But I'm very keen to open this up to questions and see what really interests you and where I might be able to shed some light. So I think it's worth reflecting on some of the background and how we got here. Of course, the current legislative landscape is the 2012 Health and Social Care Act. And we know we've moved a long way from that. That will set up clinical commissioning groups. We've had a lot of change in the time being. We've had the 5-year forward view and the dawn of sustainability and transformation partnerships, STPs, and more recently the long-term plan, with integrated care systems as the new model for delivering care. Currently non-statutory voluntary partnerships, but as I'm sure you're all aware, the government's white paper and bill that we're expecting shortly will make them into statutory organisations replacing CCGs. And the reforms that are taking place are based on NHS England's own recommendations, and I think broadly seen as a lot more bipartisan support than the reforms in 2012. But of course, it would be missed to mention the COVID-19 pandemic and the huge strides forwards taken in integration across the system, and that's how that's brought people together. It's brought the best out of many areas, working together to combat the challenges the system's faced. But on the other hand, it also creates difficulties embarking on a period of major reform while we still have the pressures and the legacy of COVID in local areas. Now, broadly speaking, the NHS Confederation endorses the direction of travel that's been set out in the white paper as a way of enabling collaboration, risk sharing and flexibility, and ultimately improving the delivery of care that patients receive. Next slide, please. And again, I'm just going to recap on the purposes of the ICS. What are we really hoping to achieve here? Well, this is about improving population health and care. I think recognising that the way that the NHS was set up in 1948, where patients comes in, you might have a broken arm, we fix you up, we pack you off, we send you on our way, and the expectation that came with that would actually, the NHS costs would reduce in the long run because the NHS would be fixing people's ailments is perhaps unrealistic. Care demands have moved on. There's a stat I was looking at the other day, I think saying it's about 86% of demand for health services today comes from non-curable diseases, and that model simply doesn't work anymore. So how can we improve population health, keep people healthy, and also look at the multitude of different people's different health needs, given the rise of multi-morbidities? Tackling unequal health outcomes and access to services is a huge priority, I know, for many of our members, and through all the engagement and consultations we do, we keep hearing tackling health inequalities has to be at the heart of this agenda. But a large part of it as well is still about productivity and value for money. We know that the system is coming under a lot of rises in demand due to long-term increasing an aging population and multi-morbidities, and we need to make sure that we're able to keep providing top quality health services within the budgets that are available. But there's also, I think, a growing recognition across the sector about the broader role that the NHS can play in social and economic development, the concept of anchor institutions, and how that ties into population health, and that's something at the Confederation that we are strongly committed to. Next slide, please. So what's in the bill? We've seen the white paper and we have a strong understanding of what we're expecting to see when the bill is hopefully published later this month. At its core is the shift to statutory integrated care systems. But I think one of the elements that came out in the white paper that was slightly new from some of the early proposals we see from NHS England was the concept of this split between the NHS ICS body and the ICS Health and Care Partnership. Now, as we understand it, the partnership leads primarily on strategy, bringing together players from a number of different sectors, including local government and the voluntary and community sector, while the body will take on more of a delivery role and commissioning functions, including primary care, dentistry, and in time, other areas like specialised services. And we know that different areas, different parts of the country are taking different approaches to how they're going to approach these two boards. For instance, some areas we understand are going to have the same chair across the ICS body and the Health and Care Partnership, and perhaps even the same board with the ICS body as voting members and the partnership members as non-voting members. Other areas see the two roles as completely very distinct and to have two different chairs and two different partnerships. And the legislation aims to be quite enabling and permissive to allow different areas to suit what suits best their local needs. And I would be quite interested if different people to volunteer in the chat what's taking place in your area and how you see this, how you see the two different roles of the boards, because this is still very much an emerging field, and I think different areas are coming to decisions about whether they're going to have the two bodies, the body and the partnership, very closely combined or a little bit more distinct. We are expecting to see a bit more clarity on the role of these two, the body and the partnership, in the ICS design framework that we understand NHS England will be publishing imminently, possibly as I'm speaking. But I think that would be very welcome to systems and CCGs across the country who are trying to go through the process of the transition in the next year. Mandatory tendering was a key part of the 2012 reforms to encourage a system run on the principle of competition. But I think there's been a lot of demand from local stakeholders to move away from that model. That the broader focus of the white paper and the reforms taking place is about moving the NHS away from a principle of competition to one of collaboration. So NHS England has published their proposed new provider selection regime, which would move away from mandatory tendering and give much more freedom to commissioners to pick the most suitable provider or continue arrangements with existing providers where they're working. Now, there is a strong emphasis in that on transparency. There are defined criteria that not just commissioners, but anybody awarding health and care contracts in the NHS has to apply by, and requirements to be totally transparent in the rationale that they've made for these decisions, which we think is very much welcome. But I think, again, it's important to make sure that the transparency requirements are effective without putting too much burden on local systems to administer. This does raise some issues around conflicts of interest, but I think that NHS England is very much trying to encourage a culture change here. I think there is an expectation that where systems do choose to put services out to mandatory tendering, anyone who is in the process of bidding themselves has to step out of the room for that decision. But it's been quite interesting seeing the different perspectives of both commissioners and providers to the kind of the new reality that we're expecting to see from next year onwards. And the bill, very much from the Department of Health's own initiative, rather than NHS England, has put forward new powers for the Secretary of State, including being able to move functions between arm's length bodies, the removal of Public Health England and the shift to the launch of the UK's new Biosecurity Centre, and the movement of functions from NHS England to NHS improvement to NHS England comes very much to mind. But this power also extends over allowing the Secretary of State to intervene at any point in service reconfigurations, rather than at the end of a reconfiguration where there have been concerns raised locally. And this is an area of significant concern to us that I'll return to shortly. Next slide, please. Provider collaboratives are due to be established, linking NHS trusts both horizontally between trusts providing similar services and vertically between community, acute, and mental health and other providers. And it's the expectation every trust will be part of at least one provider collaborative. And we're seeing, again, a great variation across the country in how people want to use provider collaboratives. But there, one model is that provider collaboratives take a lead role in place-based arrangements. ICSs will be able to devolve functions to place. And this is very much encouraged. We've long supported the principle of subsidiarity in the arrangement of care, and NHS England is supporting this. Making decisions as close to patients as appropriate. And there are different models for place. It could be local committees with the administrative function delegated within the statutory organisation of the ICS, or there will be the option for ICS to delegate their functions to lead providers in a provider collaborative who might then go and subcontract different services. But there's also the opportunity to delegate downwards to pull together resources upwards, creating supra ICS arrangements where appropriate. One area that comes to mind, for instance, would be the provision of commissioning ambulance trust services. Obviously, London Ambulance Services covers the whole region rather than individual ICSs. And specialised commissioning is another. NHS England plans to review what's on the specialised commissioning list, but also devolve some specialised services down to an ICS level. But this won't be appropriate for all ICSs, particularly smaller ones who may want to come together to commission these services collaboratively. And there will be a duty to collaborate legally imposed on all NHS organisations, which will be defined by the Health Secretary of State for Health and Social Care. We're very keen that the definition of this encourages as much kind of self-regulation as possible in how it's managed. Next slide, please. I would add as well that we very much welcome the flexibility that's being put forward in the bill and the permissive approach. This allows ICS to do things in different ways, and the legal framework should be an enabler rather than a straitjacket for how systems work. And we're very much supportive of protecting the continued role of the voluntary and community sector enterprises in the delivery of care, making sure they're not overshadowed, making sure that VCSEs have a role, for instance, on partnership boards, and continue to be commissioned both directly by ICSs and subcontracted by lead providers where appropriate within the new provider selection regime. So sorry, previous slide. We are, as I say, we're supportive of the direction. We're supportive of the proposals for the new procurement regime, but we 100% recognise the importance of having local government as an essential partner at the table. And there is a duty for ICSs to have regard to the plans put in place by health and wellbeing boards. There are different approaches being taken place in different areas. Some areas plan to bring their health and wellbeing boards together within an ICS. Others will have delegates from health and wellbeing board in partnership committees. It very much depends on the size of the ICS. And again, I'd be very interested to see in the chat to hear about what your areas, what approaches your areas are taking place. And ICSs will have some financial flexibility over autonomy over how and where finances are used. But we think that the enabling framework should help ICSs to have the capability to really make some progress on addressing health inequalities. Next slide, please. So what are our key concerns? So earlier this year, we published a paper legislating for health and care in England, and there are 4 key areas that we've put out. But I would note that we're going to be reviewing these positions in light of the draft bill and the guidance that's being published later this month. Make sure that we're listening to members' concerns and responding to the substance of the legal changes that are now going to be put on the table. So I think number 1 for the Confederation is the increased powers for the Secretary of State, particularly its ability to intervene in local service reconfigurations. And we're very keen to ensure that there are appropriate checks and balances put in place. For instance, a legal duty for the Secretary of State to make sure that clinical advice is taken on board when he decides whether to intervene. You know, our priority is making sure that service reconfiguration decisions are taken on clinical rather than political rationale. Governance and accountability is key. I think the design framework coming forward shortly will provide some clarity on the distinction of the role between ICS bodies and partnerships and how the intra-governance arrangements will work. But one area that we've heard very strongly from our CCG members, and the priority for clinical commissioners specifically, is the importance of clinical leadership on ICSs. We see this as one of the most positive legacies of CCGs, and written to the Secretary of State, to ask them to make sure that clinical leaders are guaranteed on ICSs in law, although we hope to see in guidance further detail on the professional roles that take place, the importance of nursing and medical leaders and allied health professionals and other supportive colleagues. The duty to collaborate, I've touched upon, how we'd like to see the definition acknowledge shared goals such as health inequalities and monitor adherence through peer assessment and self-regulation. But crucially, the pace and timescales. We need to make sure that the pace of transformation that's set out in law matches the ability of local areas to keep up. And this is going to be important to making sure that we actually achieve the goals that we want to. For instance, one thing we heard very early on was the importance of getting ICS chairs appointed as quickly as possible so they get their executive teams in place in the autumn to manage the transition that's taking place. And increasingly, an area that we've heard concerns about or I guess a desire for more clarity is around the HR framework and the transition of staff from CCGs into ICSs, where NHS England has issued a guarantee of employment for staff below board level, and particularly what does that board level comprise of, and what freedom do ICSs have to use staff within their system to meet what are quite distinct needs of the ICSs and a distinct role compared to CCGs. Next slide, please. So what are the risks? I suspect that much of the debate on the bill in Parliament, as well as being around the Secretary of State's powers, will actually be about the areas that are excluded from the bill. We're all aware of the challenge facing social care and the need for long-term assessment. The government's promised to bring forward later this calendar year, but is excluded from the scope of the bill that they'll be bringing forward. And our ICS leaders and the NHS Confederations Health for Care Coalition are very much pressing the point for the need for a long-term sustainable approach to social care to be forward as quickly as possible. Any sort of kind of legal transition in the NHS always creates the risk of distraction and disruption through reorganisation, particularly at a time when local systems are trying to deliver with a substantial backlog of care created by the pandemic, and we're very aware of these concerns. There are certainly some quite ambitious expectations in terms of what ICSs can achieve, and we want to make sure that, you know, whilst we are ambitious, that also from a national perspective, national leaders are realistic. But areas like patient choice and patient resident voice are protected. We understand that ICSs will very much be taking on the role of patient resident engagement from CCGs. And of course, we can't not mention mental health. We want to make sure that mental health providers have a key role on ICSs and through guidance have a role on those partnership and ICS bodies. And that parity of esteem is delivered through in substance and in practice. Alongside wider investment in primary care, the recognition of the importance of prevention and delivering services closely to patients as possible, enabling different professions to operate to the top of their skill set. And this will all help encourage an approach of empowerment to help local systems focus on population health and managing health inequalities. Next slide, please. So what are the next steps? We're expecting to see the ICS design framework and HR framework published imminently, if not today, then at the start of next week, which should provide a lot of welcome clarity for systems. The NHS bill, putting the legislative proposals before Parliament, should come forward later this month. And we understand that it's the government's expectation that it will pass a second reading in the House of Commons before the end of July. The bill will then go to the committee stage in September and October, which we see as a key period during the transition when amendments might be put forward. And I think, you know, despite the size of the government's majority, this is a crucial time in the passage of the bill. I'd note that in the 2012 Act only had parity of esteem for mental and physical health added through an amendment during its passage through Parliament. We also expect the government to bring forward their own amendment in the early autumn, clarifying the role of the CQC in relationship to ICSs. So the bill should pass through the House of Commons through the autumn, and then towards the late autumn come forward into the House of Lords, where the government doesn't have a majority and may be another area for amendments. With the added area of interest that Sir Simon Stevens will then no longer be in his position at NHS England and will himself be a peer voting on the bill. The expectation is that the bill will receive royal assent in February and come into force in April 2022. The majority of the bill, I should say, will come into force. There will be certain elements, such as the transfer of specialised commissioning powers to ICSs, which will come under what technically called a variable commencement clause, which would enable that to be enacted any time after April 22, when both the Department of Health and NHS England think systems are ready to take these roles on. And that for us is very important. With many of the specialised commissioning functions being dealt with NHS regions, it's important that ICSs only take on some of these responsibilities when they have the appropriate capacity and skill sets in their organisation to deliver them effectively. But again, it's important for us to remember that there's a very different approach being taken to the bill this year than in 2012. This really is legislation catching up with what local health and care systems are already doing in practice and enabling them to deliver them, whereas the ambitions behind the 2012 bill was much more to impose a new way of working upon the NHS and was much more prescriptive. The bill and guidance is going to be very important to how the systems do work in practice, though. But we're really pleased to see how permissive NHS England and the government are encouraging the bill to be, giving maximum flexibility to local systems to work out what works locally and adapt their plans accordingly. Whilst integrated care systems will have statutory responsibilities, they are still going to be primary partnerships of collaboration, and it's, I think, very much recognised by many of our members the importance of not having to rely on legal duties, legal instruments like the duty to collaborate, but about having the right culture in local systems coming together as local collaborations working together in the interests of patients to deliver better care. Next slide, please. That may be the end. Thank you very much. I hope that was useful. I'm very keen to hear questions from attendees today, and I'm happy to go into areas that I covered in the talk in more detail if that's of interest. And I couldn't speak today without giving a plug for the NHS Confederations virtual conference next week, taking place from Tuesday to Thursday, where it's still possible to sign up online. We'll be having Matt Hancock, Sir Simon Stevens, and the NHS new Confederation's new incoming Chief Executive, Matthew Taylor, all speaking, and there'll be several sessions on legislation. Thank you very much. I think you're on mute, Elizabeth.
You're good point. I was just saying huge thank you. You've really made clear something that seems so complex. But you have raised lots of things I think people want to discuss with you, lots of points, and I've seen a number of questions coming up in the chat box. So I'm going to turn to our chat box facilitators, which are Pam and Kath and Liv, and ask them to pull out some of those questions and pose them to you, Edward. Thanks.
Okay, we've got a couple of questions around funding which are quite detailed, so I'll start with an easy one. Somebody, Peter Ball, is just asking for clarification. He says, did you say the key selection criteria has now been finalised and published?
No, they put the NHS England has put forward its proposals, and we as a Confederation and NHS Clinical Commissioners have submitted a joint response to that consultation, which we're broadly supportive. I would be surprised if there are significant changes between the proposals that are put out for consultation and finally what goes in the bill. But of course, I could be wrong there. There will be very different points that have been put forward.
Okay, thank you. We've got a question from Phil Winrow next around funding. Would you like to ask that question, Phil?
Yes, thanks for that, Pam. I was just struggling to come off mute then. Yeah, I was just thinking in terms of ICS, we know that they're largely going to be routing funding through the provider collaboratives. We've got instances where we are already in partnership with groups that will be in a different ICS or a different provider collaborative. So trying to ascertain whether or not there's a mechanism for routing funding down to place so that you can carry on with those partnerships or not.
Yeah, so the mechanisms will be in place for delegating funding, and then, as I said, there'll be different arrangements in place. One model will be through the provider collaboratives, another model will be through having local committees and having within the organisation of the IGS place-based teams and place-based executives who manage that funding and are accountable up within the ICS structure. In terms of what functions systems choose to delegate to place, this is very much in the hands of each individual system to decide. There is no set prescription on what should be designated to place and what should be kept at a system level. But I think you have touched on something there that I didn't raise in my presentation, which is potential for boundary changes, which is really the elephant in the room in many respects. The government is trying to encourage an alignment of boundaries between local authorities and systems, and there was a range of different views on this. But I think primarily our perspective is that systems need clarity on where there's going to be boundary alignments and where there's not. Many systems have already merged CCGs together to have a single CCG across the ICS patch, and again might need to be further variation between what areas those CCGs cover, and for the areas that haven't merged, again they need to know where they're going, and the importance of making sure that the decision is taken as soon as possible, so both all system partners have clarity on where arrangements are going to end up.
Thank you. Thanks, Edward. Pam, any other questions in the chat box?
Yeah, we have again quite a detailed question from Mark Albiston. So if you'd like to ask that question yourself, that would be good.
Thank you. So my question was probably kind of linked to the last question. It's around pool budget arrangements that are currently in place. So I think from the system that I work in, one of the concerns is around the fact that there are a multitude of pool budget arrangements in operation in the country. When benchmarking data pulled both regionally and nationally, what that points to is a significant differential in how NHS and local government works together, pools its resources. So one of the concerns that we've got as a system is there going to be the opportunity around, obviously you'd want some levelling up, but through the definition of levelling up, some systems are going to see some potentially levelling down, and it's probably a question around how that's going to work at an ICS and locality commissioning arrangement, because it's going to be some significant risks for some locality to manage in the medium term.
Thanks, Mark. I think there's a couple of important issues there. One is about budget pooling, also, but there's another about allocations. And we are hoping to get some clarity on the arrangements to which budgets will be allocated from the centre through to different systems soon. I think it's probably fair to expect that the arrangements will be very similar to what's in place now. I think we're also quite clear on the need to make sure that we have as accurate data as possible to understand things like population health need and health inequalities, to make sure that can be considered into the allocation formulas. And I know there's been demand as well to make sure that systems have flexibility on how they allocate funding within systems to different places, but also some tools and some guidance on NHS England on from how that funding might be allocated. I think the importance of making sure that at a place level, discussions can take place about how to use the available funding, not how much funding, although that's obviously going to be an area of significant passion and heated views. On the pooling side, we are expecting kind of existing Section 75 arrangements to be able to be carried on, and provisions as well. Just touching on the provider selection regime about patient choice should continue as well, and any qualified provider rules. And there should be a standardisation, I should say, as well, of any qualified provider. So limiting local areas' ability to tweak those. But in terms of how those budget pooling arrangements within an ICS and at SUPRA level and above an ICS are made use of, again, this is very much at the discretion of local systems. It is very much an approach of allowing as much flexibility to ICSs as possible. But I think at the moment we know that lots of ICSs are still working through how this is all going to work. So even once we've got the bill has been published and we can see the proposed legislative framework, how each area decides to make use of this, I think is still going to take a lot of time through the year, which is why we're very concerned about the pace and the timescales. Once all this is enacted and when we know where we stand, systems as well still need to work out what suits our area best and how we're going to play this.
Thanks, Edward. Pam, any other questions?
No, that's it now. I think we're ready to move on to the next speaker, unless anybody's got anything they want to say and put their hand up.
All right, so I had a question actually. I can see Dilys is just putting something in the chat box as well, but Edward, I just wanted to come back to your point about risk sharing. I wondered if you could say a bit more about risk sharing between providers and potentially risk sharing among system partners and what that might actually look like. Is there an example you could give?
This is a really interesting area, and actually we're due to bring out a report hopefully later this month on the systemization of medicines optimization. I think a really key area, given that medicines today are about I think the second largest area of NHS spending. And I hope this is answering your question, Elizabeth. But one area that we've been looking at is particularly around taking blood samples. And I think concerns about accountability and the risks of if a primary care provider would take a blood sample and pass it, or a community pharmacist and pass it on to local trust as a way of just making it easier for patients. I think there's lots of concerns at the moment where patients have to travel often long distances to their acute trust because that infrastructure for accountability and what that means for risk is not necessarily in place. I'm afraid I don't really have the answers on that. I'm hoping we're going to see some clarity coming through in the guidance, if not today, then part of the multitude of guidance that is hopefully going to come through in June and over the summer. But this is definitely a key area. And if systems are really to come together and work collaboratively, the risk sharing does need to be right, because ultimately if things go wrong, it's leaders who are going to be held accountable, and leaders need to know how to understand clearly how these arrangements have been put in place.
All right, thank you. The other example I've heard cited a lot and discussed a lot is the risk around performance, electives, for example, and managing shared responsibility between partners around that one.
I might be able to answer a little bit on that briefly, because we've seen some proposals put forward in the system oversight framework about how areas will be taken into I think there's 4 tiers based on their system performance. So it will be an approach from NHS England of looking at what's the overall level of performance of the system, and individual provider organisations will need to have regard to what their colleagues are doing, because a whole system will move up and down based on their collaborative strength, not just individually, and that will touch on areas like backlogs, etc.
Okay, that's really helpful. And I see a couple of other things that come up in the chat box. So can our chat box monitors just pull on those if they were actually questions, or were they more observations?
No, I think there's some important questions coming up now. So we've got 2 more. Dilys Quinlan, would you like to ask your questions? I think several people would like to hear the answer to this.
Well, it's up to now. I've not heard anything really about how either ICS or PLACE or the provider collaboratives, how they're going to engage and involve patients and their local populations, and that does concern me. As simple as that, basically. It's nowhere to be found as yet.
Okay, so how are the new structures going to engage with local people and make sure they hear the voice of local people and service users, Edward?
Yeah, thank you, Dilys, and that's a really important point. And apologies if I didn't raise that earlier on during my presentation. The expectation, well, we understand that the requirements on CCGs for engaging patient and public voice are going to move on to ICSs, and that's the responsibility is going to sit with those with ICSs. We expect organisations like Healthwatch again will have continue to have a role across health and care partnerships. But I would say that the ICS design framework is due to be published imminently, and that's going to provide a lot more clarity on the expectations around patient voice. But I think again, as with all areas across ICS, the practicalities of how this is done and what levels people engage at place, at system, etc., I think different areas looking at, you know, what's going to work best in our area. And there's this difference between, you know, what's expected and what's enabled through guidance and legislation, and how practically the different areas do this. The recognition of the importance of doing it in there. We're going to see some further details shortly on the requirements. But I think, as with other areas, as I say, I think if systems are looking at what's going to be the best way of engaging patients in our area, and there's not an immediate answer to that.
All right, thank you. So a variable model there, but clearly something that needs quite a lot of attention. Thanks to Liz for arranging that. I think we've probably got time for one more question.
Yeah, we've got a question around governance from Gordon Cairns. If you'd like to ask the question, Gordon.
Yes, can you hear me?
Yes, yeah. Thanks.
My question is, are there going to be lay members or non-executive directors on the ICS board and the place boards? It's going on from Dillis's question about patient and public involvement. I can see that I'm a patient rep. I'm also a chair of a few organisations, and I just want to know what the patient, if there's going to be a patient representing a lay member or non-executive director. Sorry, I've got autism.
Okay, we've heard you. That's a great question, actually. Thank you for raising that one. Edward, are you able to respond?
Yes, I think the short answer to non-executive directors is yes, they will be an ICS body. So there will be a requirement in the guidance that every ICS body has to have NEDs in place, including NEDs who don't have responsibilities any other NHS organisations, which I think very much opens up the route for patient voice. And again, this is something we've heard really strongly from our CCG lay members forum, the importance of having that lay, both clinical voice and patient voice. And I think we're going to see both that voice sitting on the ICS body part of the ICS, but also in a much broader sense through the partnerships, which will likely be bigger bodies. At a place level, I think the picture again is a little bit less clear. There is an expectation again that patient voice will be particularly enhanced at place level because you are closer to patients. But because the arrangements in place are going to differ so much, that's going to look different across different areas. So where there is a lead provider with a provider collaborative that's taking on place arrangements, as part of that provider collaborative committee or through the existing arrangements of the lead provider as an NHS trust, they might be having to take the patient voice through that route. Where you have local committees, you might have patients sitting on those to provide the patient view as well. So it's definitely not a one-size-fits-all approach.
Thanks, Edward, and thanks, Gordon. I saw other people in the chat box saying thank you for raising that point. I know there are other questions coming up. Please don't think there won't be an opportunity to answer them. There is going to be a panel Q&A a bit later, but I'm going to pause now, give Edward time to have a little break and catch your breath. Edward, thank you so much. Very informative. I think you've raised lots of questions. You've answered lots of them. It's clearly a rapidly moving picture, and as you said, some new guidance and information may even become available while you're online talking to us now. We will come back to you as part of the panel in a little while. So thank you so much. We're going to shift gear a little bit now. We're going to look at the creation of integrated systems and the leadership of integrated systems through a different lens, and welcome Dr. Sakthi Karunanithi, who worked as the Director of Population Healthcare for Lancashire and then became the Lancashire Director of Public Health and Wellbeing. He trained across many NHS organisations in the North West region and was a NICE scholar. Has many interests, but these include mobilising communities for well-being, integration and improvement of health and care at scale, socioeconomic determinants of health, and addressing unwarranted clinical variation. Sakthi is also the Senior Responsible Officer for Population Health and Digital Health for Lancashire and South Cumbria Integrated Care System. And you will have seen that he has played a major part in the pandemic, which of course is a living example of integrated systems working together around population health. So Sakthi, a very warm welcome to you. Again, we'll invite you to speak uninterrupted, and then we'll pose questions from the chat box to you.
Thank you, Elizabeth, for the very warm welcome. I should have really added that I have been an Aqua associate as well during my training, and it's a pleasure to be back with colleagues, many of whom I seem to recognize on the chat, and for those of us who we haven't met, hopefully this next few minutes will be both a bit light-hearted and also some space for critical thinking, shall we say. And having heard quite a lot of content from Edward, I just want to thank him as well for that insightful sharing of information. I'm drawing my talk on a couple of key experiences in the recent past. One is just before COVID hit, I was part of a small team that went on. Again, many of the organizations that are collaborating on this call supported us in that systems leadership development program with Yale University and NHS Leadership Academy. And then the second experience I'm drawing on is what's happened in the last 12, 15 months during the COVID pandemic. And I hope I will be able to locate the integrated care systems as a concept and a reality with each of us as individuals, as well as what's happening around us. And hopefully this is less of a content imparting and more of a discussion point, which some of us or many of us will pick it up through Q&A and the panel discussion as well. And one of the things that strikes me right at the heart of it is language and meaning. And without having that, it's quite hard to even understand what our shared purpose is in this ICS and CCGs and 5-year 4 views and all the rest. And if you just do a quick Google of ICS, it comes up with a lot of different things. International Chamber of Shipping, Intercontinental Church Society, an International Citizens Service, and now integrated care systems. And where I would like us to think through at the end of this, and hopefully in the future, is how do we see the integrated care systems as a means to developing a bit more intelligent and compassionate service, which also happens to be an ICS, to our residents. So that's where I'm sort of framing this conversation as. And you could interpret the meaning of ICS as a number of different organizations on the left-hand side of the picture, where each are different entities and it's just a different light, and it's seen as something else from whoever is seeing it, predominantly from a legislative perspective or a structural perspective. Or we could also develop the meaning of ICS based on what's on your right-hand side, which is different people and organizations actually having a shared purpose, and we're growing something together, and each has a role to play, and that is another meaning of integrated care systems. And rightly or wrongly, what we tended to veer towards and gravitate towards is we've got to meet certain requirements, we've got to submit certain plans, we've got to move the needle on certain things, and mainly money. So there is an inherent conflict right at the beginning as to what do we mean, and if you're working within the NHS, it could be quite stressful at this point in time, especially if you're working in a CCG. If you're working in a local authority, it might mean many different things, from lay member involvement to how is this going to fit with the existing things like health and wellbeing boards, which are also statutory, as well as what is the role of local government and wider public sector, and indeed the private sector. Looking at it from a population health angle, we need all of them to work together in tandem to create the conditions in which people live and work and play and enjoy life, as well as when they fall ill, to draw services that needs to be much more person-centered and, you know, point of care and all the rest. So as the guidance is coming out, it is becoming very clear that there will be a lot of local flexibility, and it is down, and which is to be welcome. So it is really, really important as we prepare to embrace this future, that we prepare ourselves and our people and our organizations to make the intention a reality, or intention of the statute a reality. If I could move us on to the next slide, please. So I'm not going to dwell a lot on me speaking. There's only a couple more slides, but I want to draw on a few points just based on what I just said. One that you're seeing there is exactly just a continuation of what I was mentioning before. Is the ICS a duck or a rabbit? It depends on what you see and where you are. And I would argue that at the heart of it is making a difference to the people we serve, and making a difference in the way that we're all working together better than ever before, and also bringing the best value for the public pound, and looking after our own staff who have worked incredibly hard, doubly hard, and are already worn out during the pandemic. So that becomes a really important purpose for the ICSs. And the spending power and the people power does mean that ICSs, integrated care systems, are a real institution and anchor in each of our communities, and therefore a potential influence on the wider economy and the environment as well. And I'd argue that we keep the ICS, as in the system, as the overarching framework, whilst the body, which is a statutory NHS body, that's going to be created as a means to achieve the system's goals. And as we go through the next few weeks and months, that common understanding is going to be really, really crucial. And it doesn't look like it's going to be given to us like they have been in the past, and it's going to be down to the local people in leadership roles and people in followership roles to develop that meaning and purpose. And within that, I think we've already started to unpick this, is the role of the place, and particularly the role of the neighbourhoods. ICSs and the geographies and the boundaries, quite often, given the number of them, which are smaller compared to the local places, may or may not mean anything to the local people above and beyond who are directly impacted by the ICS and the NHS structural changes. But what is going to be inherently important here, with my experience and speaking to people, is this notion of the place and understanding of the place and the neighborhoods within the place that are quite, although from 30,000 feet and from Westminster, it may all look the same. When you actually land on the ground, they are incredibly unique. Just to give an example of my experience, both from looking at from the system perspective, COPD admissions in 2 different places are higher and outliers. But when you zoomed in and start talking to people, clinicians and people having this lung condition, it would soon transpire that in one neighborhood, yes, there is a lot of chronic lung disease, but they are largely an older population who have got mental health issues and depression and living in poverty and so on. Whereas in another neighborhood, it tends to be in younger population with quite a lot of, smoking and occupational exposure, and which does require different types of solutions, although from 30,000 feet high, they may all look like the same problem. And to navigate through this, working at a system and a place and a neighborhood, working between clinicians and people who are not directly providing care, and many of us will move between them as care providers or indeed receivers of care. Managing that identity of who we are is going to be really, really interesting to develop, but important one as well. And also to withhold our prejudices, to withhold our stereotyping of what normally tends to get badged as, well, NHS is a national sickness service, which often it is, and local authorities are more of a wider determinants, but they are much more closer to people, and quite often they can be interchangeable as well. And I would argue that we need to give this a good go and a good chance for it to flourish, because as we come out of this pandemic, the next 10 years, and I can even extend to the next generation, is going to be a critical period for us to rebuild our economy and rebuild our communities and societies. And we've seen how crucial health of our population is, not just for the health's sake, but also for the wealth's sake, and particularly in the Northwest region, where we've constantly been bombarded with different waves. And if you're having one now, it's going to be really, really important to have that sense of the place and the neighborhoods, and trying to have that collective meaning and purpose. Now that is at a collective level. And then very soon we're going to be finding ourselves with the reality of money. We're seeing the demands going up already. We're seeing non-seasonal things like RSV in children, for instance, already cropping up. And there is a big gaping hole in the finances of the public purse. There will be an expectation on these ICSs, no doubt, and there already is, to continue with balancing the financial constraints. So it will be really, really important to have a shared understanding and a purpose of what is the actual problem we are trying to solve at different points in time. And if we get past that, then I think we've got a fighting chance. But quite often, what I've experienced is it's there in the words and in the vision statements, but actually in reality, there often is a need to revisit that question of what's the problem we're trying to solve. And to do that, we all need to start learning and continue to promote the using of different lenses and understanding how we can change the environment in which we operate. And they look like simple things, but even the way we talk to each other and the way that we give time to each other does generate a different atmosphere. And still keeping that all together for the sake of a shared purpose. And the purpose, in my view, is at the center of it is the people we are trying to serve, and then the people that are working in the system at the center of it. And that often there is a need, I argue, that we need to bring back to the fore often. And there's only a couple more slides, and we hopefully will enter into what I'm anticipating to be a lively discussion. The next slide, please, is mainly I wanted to draw on the silver lining, so to speak, in spite of losing a lot of lives and so much pressure on all of our services and families and on our own selves. COVID has really taught us how to collaborate when there is a common goal, when there is a common crisis. And we've all experienced this to one extent or the other. And a couple of really fundamental things that I've experienced in the last year, more than a year now, is information sharing, which is fundamental to having common understanding. And there has been quite a number of reasons why we can't share information for the sake of a common purpose, whereas COVID has enabled us to share information for caring the clinically vulnerable people, for having joint assessment of risks in our schools, in our hospitals, and increasingly we are using that same information to really support people for having their 2 doses of the vaccines, as well as this has not just been COVID, it has helped us understand the wider issues, although we don't talk about it often, like mental health crises that's emerging, like the young people issues, how they have basically lost a significant chunk of their lives due to the pandemic. The second thing that the silver lining appears to me from COVID, which will be very relevant to how we implement the notion of an integrated care system, is the use of technology. And I want to summarize that as 3Ds, the diagnostics, which you've seen, especially the lateral flow devices for whatever famous or infamous they are, the concept of near person testing, and the concept of using different devices for monitoring people in their homes, and even talk to them in clinics, they have always been there, but the need of the hour during the pandemic has really gathered momentum and accelerated the use of the diagnostics and devices and data in a very different way, that we should almost put roadblocks so that we don't slip back to where we were and build the next steps for the ICSs in there. And that does include things like people, who are the fundamental factors here, who are the ones that are going to lead or deliver change on our collective behalf. And I also think that now, with the guidance coming up and the need for more shared arrangements between organizations, particularly the local government and NHS and the third sector, voluntary commitment faith sector organizations, we have seen that when we needed to mobilize at scale on a community basis, we've seen that happening during the COVID response. And I think we need to hold on to some of those positive things, and how we continue to use the organizations that are here hosting this event to develop our future leaders, to develop our future clinicians, and generally mobilize and develop our thinking as a society and community to be healthy, happy, as well as wealthy. So managing that is going to be really, really important. And the final point is managing across sectors. I've never dealt with as many government departments as I have in the last 15 months in my last 20 years of being in this field. And that means, again, I go back to having a perspective, having an understanding of different perspectives, somebody looking at it, looking into Northwest or in Lancashire from the Westminster, and having the courage as well as the compassion to share different lenses and different understanding has been really crucial for us. And that, I think, is much needed, particularly in regions like the Northwest, where we have more vulnerable communities, we have more work to do to influence and to be advocates of the region in the government and across all the government departments as well. So that is really a positive experience we've experienced. We've all had it during the last year, which I think is very, very relevant in the future when it comes to working in an integrated care system. And the final slide from me, I think it will be wrong of me not to dwell on it for a couple of minutes, is asking this question: is there an elephant in the room? Or rather, what are the elephants in the room? Edward already mentioned social care. One thing we haven't spoken so far is the inequalities, is the unfair distribution of resource allocation. It's our inability as a society, as a nation, not to really understand the spatial risks across the country. It's the artificial partition or trade-offs we seem to be making between health creation and wealth creation. These are some of the big elephants in the room that, it goes without saying, ICSs have a major role in A, appreciating that, and B, acting on it if we were to really make a difference to the populations we are here to serve. I think with those words, Elizabeth, I'll leave it there as a question mark. I'm happy to interact. Thank you for asking me again. It's a great pleasure to be with so many colleagues this morning.
Thanks, Sakthi. That was really stimulating and so helpful. And I love that you ended with the elephant. This is a long journey, isn't it? There's so much to do, and you raised many points that we still need to grapple with. I've seen the chat box has been quite busy whilst you've been speaking, so I'm turning to our colleagues to pick out some of those questions and pose them to you. So Pam and Liv and Kath, over to you.
Okay, I think picking up on the last sort of point you made about the elephant in the room, I think Dilys Quinlan has quite 2 points to make. One about engagement and involvement, but the second one about Marmot. So would you like to elaborate, Dilys?
Yes, I certainly will. I do a variety of roles, Sakthi. Thank you for your presentation. One of them is a director of Health Watch, a local area. I also do, I'm sitting on the governing body for 2 CCGs, and I do non-exec work for a further CCG. I also work with offenders in the local prison, and I do independent advocacy to look after children. So I have a wide range, but my background is as a senior manager a little while ago. For me, engagement and involvement, as I've said, should have been clearly enshrined within the white paper, should have been a founding principle, because the words do matter. And I think as time's gone on, in the very short time that we've had this year to talk about ICS, it's clearly something that is being skated over. And I think that's one of the comments that somebody else has made. But Marmot has done so much work over the last 10 years. I mean, he's worked like a Trojan. He's clearly set out what the issues are. So there's no excuse for not knowing where to start, but you have to start by engaging and involving people. They have, as I've said, they have assets and strengths. It's not just their needs. They can bring a lot to the table. So I am disappointed by the fact that this seems to be a very important part that's missing. For me, quite simply, they're not patients or service users. We are them, they are us. It's that simple. It's how would we feel if it was us and we were in a certain position. So they're my sort of thoughts and my concerns, really.
Dilys, thanks. Is there a question you particularly wanted to ask Sakthi on that? I think we do all agree that it's a big omission and a concern that they're not more clearly brought to the fore in the documents.
Well, unless you can see something happening, each area is going to be different, and it's we've had issues of say 4 CCGs have gone down to 1, and in the process of that, the patient has just been completely removed from the local area. So how do you get that back?
All right, Sakthi, any thoughts on that? Thank you.
There is something about what's in the. I mean, it would definitely. I agree with you that having those words in the statutory instruments would be a major expression of the national government's intent. On the other hand, so what if it doesn't? So what are we going to do? I think that's where I am hopeful that the guidance would at least not hinder us if we have the courage and the compassion to actually embed that in the ways of how we design our local work. And as you know, Dilys, and everybody on the call knows, the more we engage earlier on, even in the thinking and the design of what we're going to do this, the better we're going to get the public consent. And we're seeing it time and time again. Even with the COVID, through 3 waves, the public aren't coming forward for as much testing as possible. So I think we need to constantly go back to that point.
All right. Thank you. Thanks. Next question then. Thanks, Pam.
Okay. And I'm sitting in for Mary Ann Hobbs this morning.
The sound quality isn't very good, I'm afraid. Hello.
I can step in if Pam's sound's not working. We've got an excellent question from Grenville Page about the role of PCNs and whether they can kind of become equal partners in the system. Grenville, I don't know if you'd like to clarify and elaborate a little more.
Yes, more than happy to. Have I gone off mute?
You have.
Yeah. I think if we're going to get really serious about addressing the inequalities and the population health around our communities and our neighbourhoods, we really do need to ensure that the primary care networks and the primary care have really got that power and voice in the system, where they can be working collaboratively around the neighbourhood with other community providers and housing and the voluntary and community sector to really unleash the potential, which I think we've been talking about there, to provide those early interventions, reduce the escalations, build on the community strengths. And I think that is a huge opportunity that could have a massive impact on keeping people out of the very expensive statutory services and unnecessary flows into hospital. But the question is, for me, how do we and can we actually see the PCNs and primary care being a real equal partner amongst the collaboratives, when in all fairness, you know, we've been talking about collaboration ever since the 5-year forward view. And that 5-year forward view talked very much about doing the right things for people we serve, and that trumps organisational priorities. And a system that has historically been predicated on the tariff system and rewarding activity. Are we going to see those changes as well with the ICS about the performance regime that is really rewarding the population health improvements and looking at the investment on a much longer time base rather than just the annual?
Yeah,
there's some real challenges.
The test of the success of the ICSs, one of the successes, in my view, should be a clear demonstration of shift of resources from more reactive, higher cost care to more proactive primary care. What is likely to happen, and there is already, that's another white elephant in the room, let's say, when we see the provider collaboratives, they are going to be bigger than what they are now, and the environment needs to be conducive to shift resources, and one of them is the role of regulation, and the other one is possibly patients in our population as well, because there is a conflict. Are we prepared to wait for more for our surgeries, for example? So these are really, I think we need to manage this as an unsolvable problem than pretending that there is a simple solution to these.
And it also goes back, I think, to the role of non-execs to keep the system honest so that we are truly doing the right thing for the patient and the communities, rather than being led by organisational priorities. Thank you.
Thanks. Thank you, Grenville. Pam, any other questions coming up in the chat box?
A few. I'm just trying to work out how much time we've got left. We've got a reflection from Hannah McKay on the level of tech adaptation, which has changed during COVID. Would you like to elaborate on that comment, Hannah?
Thank you. It's only really that we embrace the legacy of the adoption of tech. I'm a GP, have been for a decade and a half, and some colleagues have felt it's innovative to pick up a telephone and talk to patients because they've exclusively seen patients face to face. Throughout COVID, there's been a massive adoption of non-face-to-face consultations. And I think that needs to remain in a way that meets the needs of the patients. It mustn't be restrictive, prescriptive, and at a cost of patients feeling that their care is being provided in the way that they wish. It needs to be a joint conversation, and all the tech and kit that organisations are looking to embed and entrench within primary care and secondary care. We need to work together to make sure that patients benefit from it as best as possible. So it was more a kind of reflection than a specific question or query.
Thank you. Thanks. That's sort of endorsing Sakthi's point about the tech. Thank you for that. Pam, any other questions? We do have a little bit more. If not, we will. You can still pose questions for Sakthi, and we can put them into the panel. So maybe another one or two to Sakthi, if there are any.
Yeah, we've got Keith Hackett's making an observation about some of the investment made by NHS England in social providing that doesn't seem to have been capitalised upon. Would you like to elaborate, Keith?
I certainly will. I won't use the video for two reasons. One, it's rather dark in my house at the moment, and two, basically the bandwidth isn't very good. So I'll just stick to the sound, if that's okay. All it was is that I've been involved with social prescribing really from its early days, back in sort of beginning of the 2010, 2011, all the way through to where we are now. And I was a little disappointed, I suppose, to see read that the ICS, or the use of ICS and that the creation of ICS still seems to be quite a top-down, almost regional type of integration of capacity and capability, and the activity which NHS England has been undertaking in the last couple of years vis-a-vis investment into social prescribing as a capability, i.e. putting up from that hyper-local, if you wish, capability at a community level, and the integration across VCSE and local authority and local council, bringing in people who can actually signpost to the community. That there's still that gap between the ICS as this new magic wand and that hyper-local community. And I was hoping to see something, and in fact hoping to get something from, if like the Confederation, in terms of the first presenter, the closing or the narrowing of that gap. And frankly, I've yet to see it. And that's all I wanted to share, I'm afraid.
Thank you. Sakthi, thoughts on that one?
Yeah, it's a really important one, this. We just need to, as a group, as a collective, as a community, we just need to embrace certain things, even if it means letting go of previous things. And social prescribing is another one, which is, the social and prescribing doesn't go together, but put that to one side, it's such an important ingredient in bringing personalized care, primary care, and public health and the wider determinant really together in reality. And I think this is going to be requiring some real joined up thinking between these three big elephants in themselves to work together at a local level. On the other hand, we tend to see this as addressing inequalities. And if you just unpack that, we also need to make the best of what we have without burning ourselves. So there is a real distinction between healthcare inequalities and the variation in the care, and health inequalities, which is the variation in the conditions in which we live. And often what I, sometimes, not often, I experience is suddenly there is a huge interest amongst the NHS colleagues who have seen the light that the world needs to change for the NHS to succeed, and therefore becoming, basically all of us becoming sons and daughters of Marmot. On the other hand, there is a group of other sectoral colleagues thinking, well, the economy can't really change just by the NHS. So we just need to make the best use of what we have, and primary care networks and social prescribing really are at the heart of they are the boundary spanners in what we learned from various things that we worked on. And social prescribers need to be more supported, But once you put that on the table with the local authorities and the VCFS, you can leverage much bigger resource and much closer to the communities and in a sustainable way.
Thank you, and thanks. I thought it was a really useful distinction, Sakthi, you made there. So thank you for that. I'm going to draw your section to a close, Sakthi, and say enormous thanks. I think you've offered a really different and complementary perspective to Edward's. We will come back to you on the panel Q&A later. And I'm going to move now to introducing our third speaker, who will offer again a completely different angle, which I think will be really refreshing and complementary. So I'm welcoming Mike Roscoe, who's Senior Operational Lead for the Community Service Care Group at St Helens and Knowsley NHS Trust. Mike started his career as an NHS graduate management scheme trainee, and since then has held operational roles across the Northwest. These included all-age mental health services, children's services, acute medicine, and most recently, the creation and development of the Integrated Community Care Group at St Helens and Knowsley NHS Trust, which I should note was rated outstanding by the CQC, which is a tremendous achievement. And more recently, as a result of the COVID pandemic, Mike's worked alongside a team of senior leaders across local authorities, CCGs and providers to collaborate and enact the hospital discharge guidance, which I know has occupied many nationally. This programme has brought together multiple boroughs' organisational pathways and cultures during a time of crisis. So you're going to describe some of that story, Mike, I think, aren't you, and tease out implications for collaborative system working going forward. We really look forward to what you have to say, Mike. Welcome.
Oh, lovely. Thank you very much. And it's a real pleasure to come and talk to you, really, and have an opportunity to reflect with so many on what the last sort of 15 months has looked like. So, I suppose first I'd just say thanks to Edward and Sakthi, because they created a really good foundation to build on, really, with regards to this sort of concept of integrated working and collaboration. And what I want to try and offer now are some of my reflections. If we could just go to the next slide, please. So, as just said, I suppose I was thinking long and hard, really, about what was the best way to maybe frame some of the experiences that I've had, because we've done a number of different, and I'm currently doing a number of different place-based pieces of work in a range of the boroughs within the footprint of the organisation that I work for. But actually, and whilst some of us are absolutely sick of talking about COVID and are desperate to move away from it, there's a real silver lining within COVID, if I could take anything from it, in that it's created a tremendous opportunity for collaborative work to happen. And I wanted to, I suppose, use that as the test case to reflect back on. And I'll talk a little bit about COVID, but I suppose talk more about some of the principles or foundations that came out of COVID for me, which hopefully will be the bedrock for what we do in more place-based working around our system. So just go on to the next slide, please. I think what's really important to just say at the very start of this is a very personal reflection. So this is a reflection from my perspective on what the last 15 months and prior to that has looked like. So I wouldn't want to say that I stood here as a formal representative of all the organisations involved in what we did throughout COVID, although I would hope that a lot of what I'm going to offer and say would resonate with all the colleagues who we work really close with over the last couple of months. So certainly not stood here as a philosopher passing down pearls of wisdom, but hopefully there'll be things that I say which will really resonate with others on a very practical level about things they've either experienced or may experience as we move forward. Next slide, please. So just to tell you a little bit about our system, really, and paint the picture. So when I talk about our system, and it's interesting thinking about sort of what Edward has talked about and Sakthi, and then what's come out of some of the conversation around all these different names, I suppose. We've talked about neighbourhoods, where we've talked about places, we've talked about ICS, region, sub-region, and lots of different prescriptive terms. You know, the area I'm talking about as part of this conversation is what you probably refer to as mid-Mersey. So within our ICS, which is Cheshire and Mersey, you can sort of split it into three, with North Mersey, Cheshire Wirral and Mid-Mersey, which is the area I'm talking about. And it's a portion of Mid-Mersey which involves 9 organisations who are all represented on the screen, but so much more with all of those, because actually those 9 organisations are responsible for the direct delivery of care and services in the St Helens, Knowsley and Halton footprint, or they're in a role where they commission a huge amount of services and care delivery across lots of other organisations. So lots of these are conduits for a myriad of other organisations who are involved in what we did throughout COVID. I suppose going back to that comment before I was making around the different terms, I think the biggest thing for me is that place isn't new. And I know we've talked a lot today and heard a lot about some of the really helpful guidance that's come in legislation. But actually, for me, the concept of place isn't new. And I think that's a really important point for me when I've reflected back on that, because within place, then, the population, the residents, the organisations, there's a real history there, and a rich history and a rich tapestry of events and scenarios, dynamics that have played out over a number of years, which are really important to be mindful of when we're thinking about how we progress forward as a collaborative piece. And when I think back about the footprint, which I talk about, there's a rich history there, really, and a real differing landscape when we think about the 3 places of St Helens, Knowsley and Halton, who we were all brought together over the last sort of 15 months. And I suppose the maturity, if that's the right word to use, with regards to progress that's been made around place, and that's not levelled as a criticism at all. I suppose it's my reflection on just the journey that all of those different areas that have been on, really, for a whole range of different reasons. On to the next slide, please. So I suppose this is reflecting really and building on what I've just talked about there with regards to setting the scene. And again, for me, these are all really important principles to be mindful of, again, when we're thinking about the plans and the very practical things we might want to do within the places that we're working in. I think it was Ed who referenced it earlier on when talking about some of the legislation that's come in and some of the previous legislation and frameworks that have been in. We're moving out of what I would call a world of competition and a marketplace that's been around now for quite a number of years. And it's a very personal reflection, but I think I've seen more negative consequences play out as a result of that, as opposed to the positive benefits which we're hoping maybe to be realised. And again, that's a very personal reflection, because actually what we saw were organisations pitted against each other through tendering exercises, through the movement of resources around the system, setting up a brand new services, either in isolation or working with other partners. And it hasn't necessarily always been done. Certainly been done with the right intent in mind, but the outcome has sadly probably created some tension and dynamics within places and within systems, which again are really important to remember have occurred. Because I think it's fabulous, and I couldn't be a bigger advocate of collaborative working now as we move forward into the future. But I think it'd be remiss of us to not recognise that there will be baggage within those places because of the journey that we've been on personal levels between individuals, on organisational level between organisations, and within those places, I think there are dynamics and tensions there that need to be recognised and appreciated, and maybe even worked through to think about how can we now move forward collaboratively to enact what the legislation and what the framework and guidance is asking us to. I think the other really interesting bit, and I talked about the maturity of place, and I suppose what I meant by some of that is when you reflect back onto your own places and neighbourhoods and footprints, there'll be lots of different models of care delivery, and that's couldn't be more true really within our footprint when we think about that sort of that mid-Mersey area. There's services and care delivery operating in parallel with each other. We had services that had started an integration journey. We had services that are working in a hybrid form. And we've had services and care being delivered in an isolated fashion as well. And again, lots of that is because of the journey that organisations, services and areas have been on for many, many years. And I suppose I'd offer that probably an imbalance potentially of priorities between health, social care and other organisations. And that will have been born out of the way in which funds are allocated, the demographics of that population, the culture and the history of what's gone on within that space has meant that things haven't necessarily always lined up. And again, I think all of those things were potentially true of the footprints that I'm talking around within St Helens, Halton and Knowsley. And I suppose when you reflect back on that, it doesn't provide immediately at the very front all of the ingredients you need for amazing place-based working to start at the off. Actually, what it's created was a real mosaic of dynamics and setups which we needed to work through really as partners to think about how do we now move forward. So we've got consistency in what we needed to do in enacting the guidance that came as part of COVID. The next slide, please. And actually, COVID probably created for us the burning platform. And I suppose my reflection is that it was strangely uniting. And I think there was a conversation earlier on, I think maybe when Sakthi were talking about it, in that what COVID did do is it united everybody into one common goal. And that's about what could we possibly do for our population. And I think it was maybe came out in one of the comments, and I really like that trying to talk more and more about our population and our residents as opposed to our patients and our service users, because actually that's what it's all been about. And I think COVID has allowed that conversation to flourish in a way in which we may not have expected it to. So some very technical elements really with regards to just painting a picture of what the ask of us was, because I've talked a lot about, I suppose, sort of the context for us. But we were provided some COVID guidance. Well, there's been a plethora of COVID guidance, but one of the things which came out as part of the COVID guidance is that we needed to introduce a discharge approach which was consistent. I'll talk a little bit more about some of the specific principles of that, but a very, very specific set of guidance really which was NHS developed, but really was there for local authorities and NHS to work hand in hand to think about how they would enact. And I think one of the things which really struck me was what that played out as part of the conversations we were having then as organisations and as leaders and as partners was, we had a bit of an equation that we needed to get to a solution, in that we had a number of our residents and the populations from our boroughs attending the hospital and our emergency departments who were very poorly, either with COVID or with other health challenges. And we also had a cohort of residents in our population who were in bed who received care within the hospital. And what we needed to try and do was balance that to provide as many simple and safe opportunities for patients in bed to return back to more familiar places of care within their home environments or other environments which they would call home, to allow those residents who were attending the emergency departments to get the care that they needed. And what I loved about that, whilst an awful challenge in many, many ways, is it allowed us to have that group conversation about these are all of our residents, these are all of our population, and what can we now do together to try and balance this in the safest way possible. Next slide, please. So the challenge. And it couldn't have been a simpler challenge in many ways, and yet also the most complex challenge I've ever been asked to face, in that we were asked to introduce a very simple pathway out of the hospital for residents across the footprint that the hospital was covering. And within our organisation, it's relatively complex because we actually feed into 4 boroughs most of the time. So St Helens, Halton and Knowsley are 3 key boroughs, but we also feed into Liverpool with a lot of patients as well. And thinking about what I've just described, where all of those places are in very different spaces with regards to developments and the dynamics and the architecture of how they delivered care and were set up as service and care delivery parts of the system. What we were asked is to try and do something that was very consistent across the board, that would allow us to do things in a timely manner. And what that meant is that we need a system, single point of access, to channel discharge energy into for patients to leave the hospital. That the information we were enacting and sharing needed to be minimal but safe to make sure decisions could be made around our population and our residents. There were clearly restrictions in place around the physical interaction that was available. So as much as possible needed to be done in a remote fashion, or virtually, digitally, or via other means, and that it needs to be done as quickly as possible. So talking about 24-hour turnarounds, 48-hour turnarounds, some of the decisions that need to be made. And an important one, which I think would be remiss not to mention, is that I wouldn't say it was a blank check, but resources made available that have never been made available before to allow us to be creative in how we're going to approach this as an entire country, and absolutely Cheshire and Mersey, there's opportunities for us to access that as well, which really, really big challenge, but one that all partners stepped up to the plate to work with us to enact. Next slide, please. So what I want to talk about now really is the approach, and what I wanted to give is a little bit of a sense of what the framework looked like for us, but actually some of the key principles which I think as a group we decided were really important, and actually I think go back to are the foundations really that we want to be thinking about as we move forward, as we come out of COVID within our places and within our wider system. So one of the big things that I talk about all of the time really is about that constant conversation. Relationships could not have been more important than during the crisis we've just been through as part of COVID. But actually they can't be more important, and I can't stress enough how important I feel they are. Relationships being front and centre, both with our residents and between organisations. Those relationships are key to help us move out of the past that we've been in, where there's been dynamics and potential agitation between some of those parts of the system, to help us move forward so that true collaboration can flourish and can really be energized, I suppose, within all those different systems. And I made sure that I was trying to play a key role in promoting and pushing for constant conversation all the time between all of the partners. And I suppose what that allowed me to do, and again, speaking from a very personal perspective, is building up those relationships meant that when we got to some difficult decisions, I was able to sit in a space where we were able to arbitrate really objectively, because within my role, I was a representative of community services provision. I understood what was going on in the hospital, but I'd also started to build up some really strong relationships with local authority leads, our commissioning leads, and provider leads within our 3 boroughs. So I was able to, I suppose, sit and help talk through some of the real difficult challenges that we were facing as a system, and putting up as much thought as possible into how were we going to reach a decision about some of the things which were coming down the pathway for us. And I talked about how do we land things. So we had a very simple framework in place with regards to how we were interacting. So we had a bi-weekly steering group. So every Tuesday and every Thursday we came together as 9 organisations virtually. Well, first of all, it was face-to-face, and it was hybrid, and it was virtually as the digital technology sort of evolved. And what we came together twice a week, every single week for an hour to work through a bit of an action plan essentially that we had. And I'll talk a little bit more about some of that governance in a little bit. But what happened behind the scenes for that, I think, was even more important, was that coming together, in that I would be interacting with or putting together some of the partners to interact, to think about how might we want to land some of the information that we were garnering about the performance that we were seeing with regards to us enacting some of this guidance, and how would we land some of the tricky situations that we were going to face, which would mean that some organisations and some services might need to bend and flex more than others to allow us to get into a place where we were as consistent and efficient and safe as possible. So again, that constant conversation was numerous phone calls and virtual Teams meetings, and investing a huge amount of time and energy into something which I just think is so valuable between all of us, and providing that courtesy really and the respect to have those conversations in a safe space, which would then allow us to have some real pragmatic conversations around what it is that we needed to do next. I've used the term governance light, and I think governance is incredibly important. Because obviously that's what keeps us safe, and that's what keeps oversight about how we move through and make some of the decisions that we need to make. But I use the word light because actually because of the scenario we're in, where we were in a crisis and we need to enact things incredibly quickly, what we then agreed to do is that we would have a very light approach to how we were overseeing it with regards to our agendas and our action plans and the way we were capturing action notes really out of the conversations we were having throughout the week. And what that allowed us to do was move forward and really focus on action, really, rather than reflection on what we have done or haven't done. It was very much about, so what are we going to do now? And the key focus of the conversations we were having then twice a week, every Tuesday and Thursday, was looking at the information. So the data is really, really important on an operational level. And I think that's what I'd really implore us to think about when we're looking at other projects in a place-based perspective, is what data are we going to use and facts are we going to use to help prove or disprove some of the hypotheses about the things that we want to change or enact. One of the problems which I've found throughout my whole NHS career is that sometimes anecdotes cause more problems than anything you could ever imagine. So anecdotal feedback on, I've seen this happen, I've seen that happen, I think this is what's going on. Often what that does is distract from the reality of what's going on and allow us to unpick and solve those problems. So what we've got really adept at, and I think I really enjoy doing, is going down the rabbit hole. So anytime we make an observation on the data or an observation on the information that we were giving ourselves based on how things were performing, we would make hypotheses around what we thought was happening or maybe wasn't happening. And we'd follow that down the rabbit hole then. And we talk about that every single week about, right, we need to go down the rabbit hole with that problem. So we'd do audits, we'd have conversations, we'd have reflections, we'd go and speak to clinicians, social workers and people involved to try and really unpick what is it that actually happened and then play that back to the group. So we had some real clarity on what it was that had played out. And the momentum was incredibly important. So the momentum, I think, is the other big thing, which I think we've got to make sure that we don't lose sight of as we move forward with other projects in our place. In that coming together twice a week, whilst it might sound onerous, actually, I think that's been the key principle in allowing us to move forward in the pace that we were able to move. And from reflection, when I think about our Tuesdays and Thursdays meetings with 9 organisations, it's a big amount of time we're asking to come together. But I don't think we've ever had a session where those organisations haven't been represented. They've always made sure that we've turned up to be part of the conversation. We've hardly cancelled any in the last 15 months. And actually, I really enjoy coming to those spaces to reflect back on the progress that we've made. And because of those key principles and those ingredients, what it really allows us to do is we have a safe space within that footprint and we have some real honest conversations because the intent is there. People trust the intent of why things are being fed back, because it's all about how do we improve this and make this better for our residents so that what we're doing truly is as safe and as efficient as possible with regards to discharging them. Next slide, please. So what did our response look like? I've talked a little bit about it, and I won't dwell too much on this because I suppose it's a very practical, technical reflection. But I suppose I just wanted to illustrate the progress we've made off the back of the challenge that this gave us. So what we now have is exactly a single point of contact architecture within our footprint. So what that means is all of the information from the organisation flows through a hospital-based single point of contact, which was never in existence. And they now interact with each of the 3 boroughs, and indeed with Liverpool as the 4th borough, but as they have a smaller content of residents who flow into Liverpool. They also then have their approach to what the single point of contact for that borough looks like. And what that brings together is health, social care, and other partners within that borough to receive all the information from the hospital and then make informed decisions about how to best safely support that resident in the next steps of their journey. Every single day we come together with lead clinicians and professionals within those boroughs to do a daily patient tracking where we have conversations about all the patients who are ready to be discharged from hospital and put plans in place to support them in a safe way. I've talked about the steering group that's in place and continues to be there. And we also have a weekly interaction where we look at some of our real complex patients who is multifactorial with regards to what we need to think about with next steps. And I suppose what I would say is we've just seen constant, slow, steady improvements, which is exactly what I think is a successful thing to see. It's not big bang. It's not been a huge overhaul. It's been progressive steps, which we've reflected back on and then moved forward as we've gone along the journey that we've been on. Just onto the next slide for us, please. Now, this is a very busy graph, which I don't expect people to try and interpret, but I'll just give some key principles because it's going back to some of the data which we collect and see with regards to the improvements that we've made. And what we've seen is from April 20 through to April 21, the amount of patients being supported and discharged on a weekly basis is gradually increased. So each week, the numbers that we're able to support leaving the hospital safely has very gradually increased. But actually, the pace in which we've been able to move through the sharing information and the interaction with each other and the planning for those patients, we've seen us move from 10% to highs of 10% to highs of 30% being enacted and planned within 24 hours. And then from 20% to highs of 50% of patients being able to leave the hospital within 48 hours of being ready to leave. And this is all due to the close working relationships and plans being able to pull together as a wider system, which is seen as continue to grow and succeed, I suppose, if that's the right term, with regards to us being effective in implementing the guidance. On to the next slide, please. So what next? So I suppose I talked a little bit about at the start, and as I've moved through this sort of conversation, is the borough-based place developments now are the really exciting parts of what's happening next. And all three of the boroughs I've sort of referenced have their own plans and programs of work, which were either happening prior to COVID or are launching post-COVID, but many of them actually just being re-energized from where they were before COVID. So in St Helens, we've got St Helens Cares, which is a program of work bringing together the place leads from voluntary sector, local authority, CCGs and providers. In Halton, we have One Halton, which is doing something very, very similar. And I say in all of the boroughs, there really is that place-based approach, which is really starting to be energised and motoring on as we move out of COVID. But what I really hope supports that more than has ever been there before, and again, this is from a very personal reflection and perspective, is that we've created some real tacit relationships and interactions between some of those key leads who have been so successful in working together as we move through COVID, to now apply the energy that needs to be applied to move place forward. And actually a huge amount of the groundwork has been done with regards to what we know about each other, what the relationships are with each other, and I suppose actually allowed us as organisations to move past some of the history that we've had and actually bring us actually to only ever really be reflecting on the past 15 months we've just been through and how well we've worked together and what it is that we can do now. So for me, it's created a really, really positive backdrop off the back of the biggest crisis that anybody has ever felt, really, which I think could be nothing but helpful with regards to what it is that we can do next within our place. I think what it also allows us to do is be more prepared for when we have winter challenges than ever before, because some of the systems that we put in place are more robust. And I think it's opened up the evolution really of what's actually possible within place more than what we may have thought was possible prior to COVID. So just to summarize, really, I think the big things which I've certainly taken away, and I do truly hope have resonated with the people who have listened, and I've seen some colleagues from our boroughs who have been part of this journey with me, is that constant conversation, whilst a huge investment of time pays its dividends, being able to move things forward in a pragmatic way to remove some of the agitation, because sometimes being in place around decisions that need to be made around changes to services or infrastructure, that the governance is really well thought through to the point that it doesn't hamper but enhances how we work together and allows us to be nimble and flight of foot with regards to the decisions that we make. That momentum is incredibly important to make sure that we have a real laser focus on how we enact some of the things that we want to enact, and don't allow too much time to pass before we reflect on what we've done and how that has impacted upon the residents and the population. That data and rabbit holes are key to removing anecdote and actually proving and disproving hypotheses to the benefits of the programme being a success. And ultimately, this has all got to be about relationships. It has to be about our relationships, and it has to be about us trusting the intent of each other to ultimately be about how we're improving the care delivery to our residents, but then also about the population health. So I'll bring myself to a close there and hope some of that's resonated with people who've listened in different positions within the systems that they're in, and happy to take any questions.
Mike, thank you so much. It definitely has resonated, and you've really made come alive some of the intentions of system integration. Thank you. A very powerful example there. And I loved what you said. I'll just quote what you said at the end there. You think this has really opened up evolution of what's possible in place. And I think that's a great sort of ending point. I'm going to ask the rest of the team if there are any questions in the chat box for you. I saw the people making some sort of statements. If we could try and tease out any actual questions for Mike, and then we'll move into the panel.
Yeah, we've got a lot of people having a discussion here. There's still a lot of concern about the lack of patient voice, and then discussions about different ways of structuring organisations. I think there's appreciation of Mike's honesty of the things he's been through.
It's good.
We've got one question coming in from Julie Dunning, who is asking how you intend to involve and take the workforce with you. If you'd like to answer that, Mike.
Thank you. That's a really, really helpful question, and I suppose has been a key part of how we tried to do some of the work that was going on through the last 15 months, and indeed what we're planning to do as we move forward, because we were desperately keen for as much of what we were enacting to be led by people who are actually tasked with doing it on a day-to-day basis across the clinical workforce and the professional workforce in the community. So the way in which we went about it as we progressed through is we held a number of, I suppose for want of a better term, rapid improvement events. And what we did, and it's interesting, and I think it was one of the delegates who talked earlier about sort of that digital evolution, and actually we've seen the digital evolution play itself out in the way we interacted as a footprint, really. So the very first rapid improvement event we did was face-to-face. So we had social workers, we had nurses from our wards, we had therapists, we had discharge coordinators, and a range of other roles all come into a huge education centre room where we did some fishbowl exercises where we were talking through a particular process and get people to comment and observe about some of the challenges they were facing, how we could unpick it. And that led to a whole range of actions which really supported, I suppose, the evolution of some of our processes. And we've done that now on 3 successive occasions. And our last one actually was probably the funniest one I've ever been part of, in that it was a very hybrid session, in that we had a huge screen with a load of delegates on who were contributing, and then also a room with a load of people who were socially distanced, doing breakout groups and all manner of different ways of interacting. But as much as possible, the people who were contributing to that were people who were dealing with plans for discharge for our residents on a daily basis across all those disciplines. And I think that's what's been really powerful, because they were contributed to what they were delivering and building, and then enacting what they just built, and then feeding back on how that had played out and what it is that we needed to change next. And all of those people are going to be involved in, I suppose, the future plans that we have with regards to what we want to do next from a discharge perspective. And just a final piece of that, as we've just literally come out of an evaluation period, and what we did as part of that evaluation was we went and interviewed all manner of people in a structured fashion. I think it was over 40 different representatives from social workers, therapists in the community, nurses in the community, and the hospital, to really get them to reflect on what the past 15 months had looked like, what worked for them and what they wanted to look differently. And they've now contributed to our future plans as part of that formal evaluation. And I think that's been key, in because you can dream up all manner of architecture that you want, but actually if you don't involve the people who are going to enact it, then you don't see the problems at the start which you need to unpick before they trip you up.
Thanks, Mike.
Thank you. Any other questions coming in for Mike?
Yeah, we've got a question from Keith Hackett about, he says, what's the key to your governance flexibility?
I suppose it's a really helpful question. I think probably trying to use the digital technology as much as possible with regards to us being efficient. So I think rather than having minutes and spurious minutes, we were recording all our sessions so that we had them if we ever need to revert back to anything. But really being very clear on the agendas being really short and succinct and separated out so that we had a very focused agenda on Tuesday. The Tuesday and Thursday agenda was very different. Tuesday was a very practical reflection on process of what was working, what wasn't working. Thursday was looking at our data and what that was telling us or not telling us, and trying to, and I suppose hopefully with my key German skills, although I'm sure some colleagues would offer different feedback on what that was like, being dead clear that we would only ever stick to the 60 minutes, and if anything we try and keep it under 60 minutes, because we all know how easy it is for meetings to be overrun and fall out into other conversations. So trying to keep it dead clear to the 60 minutes. Trying to keep it very clear on what's the matter in hand with regards to the agenda, and being very, very action focused. So trying not to allow too much of the conversation to turn into, as I talked about, just anecdotal reflections of what we thought was happening. It had to get ourselves into an action. So I suppose when I've talked about governance light, it was a very, very, very tight and short agendas. It was action focused. Minutes for us to converse about at the start before we got into the real information, and trying to move as much away from conversation in that hour to more around action and the what next, Keith, I suppose.
Can I just follow on that point, Mike? Because in all the work I've done with people during the pandemic, almost universally they've said that they found the governance light approach to be really refreshing. It'd be something they would want to hang on to in the new normal. How are you going to try and embed it in your governance processes going forwards?
I mean, I suppose what's probably really helpful is that when we think about what we're going to be doing next in place, so many of the leads who are involved in the discharge work will then be the place-based leads who are involved in the place-based programs of work. So actually the exposure to operating in that way is really, really enhanced. So I don't anticipate that there will be a difficulty in trying to apply the same sort of methodology. And like you say, I think we've all found it refreshing with regards to how we did the discharge work. So I'm hoping, fingers crossed, that we all jump on the back of trying to enact it in the same sort of way with the other work that we're looking forward to doing.
Great, thank you. Thanks. So Pam and colleagues, any other questions for Mike?
No, we've got some coming in for the panel. So I think...
Right, okay. So I think then let's thank Mike very much indeed for that presentation. I see you've triggered some requests for the slides. So just to ask you, Pam, are the slides shared normally?
Yeah.
Yeah, they will be. And to say huge thanks, Mike. And I think what we've heard are 3 wonderful presentations offering us very different perspectives, national perspective, ICS and place. And we've heard a policy and commissioning angle, a population health and sort of integrated provision angle, all of which I think have given us some great material to reflect upon. So I'm going to invite our panel members now to be approached with some questions. And I'm going to take Chair's prerogative and pose the first question, which builds on something, Sakthi, you said when you talked about leadership development, because this session is about leading integrated systems, and you noted that you've been on a particular leadership development course. My question to all 3 of you, excuse me, is how do you think we can equip leaders of the future to work differently and to lead effectively in integrated systems? And by leaders, I mean people in a disseminated leadership system at every level. And I'll start perhaps going to you first, Sakthi.
Thanks, Elizabeth. I think that's a crucial question. And I think it's more about people in leadership roles than people who are leaders. in my experience, and thanks to yourselves and other colleagues, Leadership Academy particularly, I've been exposed to quite a bit of that since my junior training days. And one thing I think is becoming really crucial is to develop in an environment that's much more closer to reality, and to develop those skills. There's already a potential in everybody. It's just bring out those things with real world problems and just staying with the problem for as long as we can, so that we go down those rabbit holes. There's opportunities. It's much more experiential and protracted over time at every level. And particularly people who are clinicians, who are providing direct care, I think we still haven't solved the problem of how do we protect their time and how do we expose them to the wider environment is going to be really, really important.
Yeah, yeah. And you talked about people being boundary spanners, and Mike, you talked about people being connectors, and how you'd done a lot of work behind the scenes, building relationships, almost creating a context, an environment to then support different behaviours and decision making. Also important as leadership skills. So I'm interested in your thoughts on whether there'll be different approaches to leader development and support for system working rather than classic clinical or organisational leadership. Sakthi, I don't know if you want to come back on that, maybe then go to
boundary spanners is something I picked up from, I think, one of the Leadership Academy Aqua work. The approach to that, with my experience, it works really effectively if we combine the individual development with a real world problem, and actually even better. Again, I really like what Mike said there about rabbit holes, really staying with the prejudices and really make them apparent to us. I think we all carry a lot of prejudice. We all carry quite a lot of lenses and stereotypes. And once you get past, this is my experience. Once you are enabled to get past some of this, then you're able to have different optics and therefore even speak different languages. And that's the main sort of feature of a boundary spanner, I think. And between neighborhood, place and system, between provision and commissioning, and finance and executive and clinical, I think that's a unique, that is definitely going to be more and more important if we are making this ICS really intelligent and compassionate.
Yeah. Thank you. Edward and Mike, don't know if you want to come back on that leadership point, or we'll move on to the next question.
Could I just make an offer on that? Would that be okay? So I think that's been really helpful. Sakthi sort of, I think, reflected sort of what was in my mind. I suppose the two things I'd offer to that as well, which I think are crucial components of how we have that more of a collaborative leadership journey between organisations. I think one is, because we're moving out of that market environment I talked about, I suppose it opens up permission for much more honest conversations between organisations. I think, sadly, the market environment created behaviours which meant that we weren't honest about the challenges we were facing, because that was seen as a vulnerability, which I just think is a really, really poor, outcome that was generated off the back of that sort of principle that's in place. And actually now that's being moved backwards, I suppose, and we're moving more into that collaborative space. It creates permission for much more honest conversations between leaders and organisations. And I think what we're also seeing, and I'm part of the Halton one and the St Helens one as well, is that we're doing some borough-based leadership programmes where we're bringing together voluntary sector, health and social care organisations to go on a bit of a leadership journey, working through some modules and having breakout sessions with people you've never met before from different departments, but with the caveat, or I suppose that permission, to have really honest, open conversations about the challenges you're facing and focusing in on the population challenges. And I think those two those two, that I suppose the framework or the landscape of allowing that permission to be more open and honest, and then structured things to help move people through with these programs, these leadership programs, I think is going to be really beneficial, I suppose, with regards to the growth together rather than growth internally.
So collaborative leadership development. Thank you. Thanks both for that. I'm going to move us on then. I think there's some more questions to the panel. So Pam and Kath and Liv, over to you.
Okay, I've got, excuse me, I've got a question from Philippa Cross, which is for Edward really, which is about, are NHS Confed doing any lobbying to ensure health outcomes are treated as being important, and if not more important than acute performance, as there's still a likelihood that system performance will continue to be judged on historical NHS measures as opposed to the impact it's making on for people.
Thank you. I'm happy to pick that up. And just before I do, just a reflection really, because my role is looking at the national reforms and working with both ICSs and CCGs who are these days working at a system level. So perhaps that's where my focus is, but it's been really, really welcome to listen to Sakthi and Mike's presentations, looking at kind of work and leadership at different levels, particularly at place and at neighbourhood, because that is so important. We as a Confed, we're strongly supportive of the principle of subsidiarity and delivering care closest to patients. And I think the point that's come through very strongly today is about patient engagement. And it's much easier to do that at a level that's much more local and closer to the populations of which different kind of tiers within the system serve. On the specific point about population health outcomes, yes, we absolutely agree with that direction of travel. I've just been reflecting on the system oversight framework that NHS England have put out for consultation and the way in which they want to assess how systems work. And there are 5 kind of key areas within that. And the second one is absolutely about prevention and inequalities and health outcomes. And this ties in quite importantly with how systems allocate their resources. And I think there's absolutely a recognition that we can't just respond to where the demand pops up, because that's so often going to be the A&E, because that's the front door. And I think the shift towards systems, the whole part of the whole point of this is to make sure that we allocate resources where they are best placed to improve population health, to keep people out of hospital and to deliver care in the right place and at the right time. And I've heard from a lot of our members talking about a move to collaborative strategic resource planning and away from the model, more transactional purchase to provider model of kind of relationships, which I think the tariff is kind of a key embodiment of. And I think if we, with resources being allocated on that basis, and the kind of the governance and oversight very much looking at population health outcomes as a whole, rather than just the volume of activity individual organisations deliver, I think we're very much going in that direction, and I think that's something that system leaders are absolutely committed to.
Thanks, Edward. Thanks. Okay, is there another question?
We've got not exactly a question, but certainly it was a question that was posed to the chat from Peter Ball, which was around people's experiences of how ICSs or emerging ICS bodies have been agreeing their set of priorities. And this refers back to what Sakthi was talking about how much can be achieved when there is a common goal. So I just wondered if it sparked a lot of discussion in the chat. I wondered if any of the panel had any comments on how priorities should be being set or are being set.
Thank you. Who'd like to start on that one?
Well, I'll have a go and break the silence. Let's face it, however we all are committed to in terms of changing the world and making a difference to people's lives and inequalities, I think most of you, if not all of you, would agree with me if I say the biggest priority that the NHS currently is facing, use the language, the NHS, not ICS, is the waiting lists and the demand and the workforce pressures. So these things are going to be given, is what I'm saying. They're not necessarily the biggest, but these are givens. So there is an element of what we can control and what we can influence, and ultimately what we need to accept. And then it takes me back to one of the comments I made, which is, yes, I completely agree with Peter in terms of courage being the leadership quality, but also clarity, and I would hasten to add compassion. But this is going to be beyond the ICS and NHS, because if you just step back and look at how the country's been affected and all the global relationships and all of that, the politics and the general philosophy of life and the economics are going to be major drivers. So one of the things that we need to go back to, back and forth, is just on the part 2 of the systems performance framework that Edward just mentioned, and try and understand how much of weighting is going to be given to that to measure success, and then work from there would be a key thing we can all be doing at this point in time. And I'm not sure, I haven't seen it, how much of the other elephants, like the inequality. So is there going to be a system performance metric on how the gap's going to be narrowed within systems? That would take you in a proper rabbit hole. And what about social care funding? So there are real big issues here. So yeah, it's not going to be easy, is the honest answer from me.
All right, thank you. Anyone else, Mike or Edward, wanting to come in on that one? The setting of sort of agreed improvement aims, really, for population outcomes, I think, is what we're talking about.
No, I mean, I suppose I'm reflecting, so I'll come in there if that's okay. I suppose I'm reflecting on some of the priorities which are being talked about in St Helens and Halton, where I suppose I'm most predominantly, and obviously they're very reflective of the demographics of the population and the challenges that we're seeing. And I totally agree with Sakthi's reflection, really, on particularly the NHS focus is very much around the waiting list and I suppose that unprecedented emergency demand which we're seeing in hospitals. I suppose the only offer that I'd give to that is that what makes me nervous is that becomes a distraction to progress in other areas where we should still be progressing. There's always a risk that, you know, accident emergency departments, for example, are always top of the priority list, which they absolutely are incredibly important because they are our residents who are at that point of real acute care requirements. So that absolutely needs to be dealt with, but not stopping us or distracting us from a place-based perspective, thinking about how we're getting upstream of stopping as much of that crisis occurring in the first place, I suppose. And I think the final bit I'd add to that is, I think, and hopefully I'll articulate this in a sort of logical way where it makes sort of sense, in that I'd be really keen to push and support for, when we're thinking about the sequence of priorities that you move through, the earlier the priority being, or the earliest opportunity for whatever that priority to be, one that's of mutual contribution from all partners. Again, what that just allows is the growth and maturing then of the relationships between partners, because they're all able to contribute equally, whether it's PCN, whether it's a voluntary sector, to the outcome or the improvement that you want to make. Because there'll be others then which will be more helpful to certain parts of sectors, etc. But actually, we've still got to remember that in so many places, we're very much in the budding parts of our relationships. So those first practical interactions that we want to have, they need to be on things which everybody feels they can contribute to and help with, because that's a real validating exercise to go through then to build on for future.
Yeah, what's important to each individual. Thank you. I think that is a great point to end the panel questions on, work on what's important to the majority. Thank you, massive thanks to the panel. I'm extending on behalf of all of the participants. You've really provided some factual updates, some really stimulating discussion points, and a vision of the direction of travel. And I think probably raised lots more questions for all of us. So huge thanks from us. And Edward, particularly thank you for stepping in at very short notice for your colleague, to whom we extend our condolences. We do appreciate you doing that. Thank you. And I'd like to thank the team that have organised this event today, because a lot of work goes on in the background, as you can imagine. And so thank you to Sue Antrobus, who does all of the organisation of the speakers, and all of our other colleagues from the different agencies in this collaborative who've helped put together this masterclass. We're just dropping into the chat box what we call our flipping book, which is our little electronic prospectus of the masterclasses coming up throughout the year. So please do enjoy browsing at that and put the dates in your diary. And there's a very warm invitation to you to be registering for the next one, which is very much linked to what we've been discussing today. It's on digital transformation at speed, and that's on Friday the 2nd of July. And we hope very much to see many of you at that one. And please do pass that on to your colleagues and your teams as well. So before we break, a big thank you to all of you for your lively participation. And we'd like, as always, to ask for feedback. What could we have done? What worked well for you? What could we have done better? And we're just going to put a little link to the evaluation survey into the chat box now. Very grateful if you could take a minute to complete that. And then it just remains for me to thank you for completing the evaluation, and then to wish you a very happy weekend, happy and healthy weekend, and say again a final very big thank you to our speakers.